Yeah, you introduce yourself?
Yeah, absolutely. So I'm Elaine Lindfield. I'm the Dementia Care Lead at East Sussex Healthcare Trust. When we gave the presentation, one of my team members, Kat Smith, was with me as well, but unfortunately she's sick and she couldn't be here today. So we came back in September to apply for the project, and we were successful in getting the funding. And you all know the criteria that's asked for when you come to this session today. So our wish was to improve the services we provide in the acute hospitals by trying the use of Lulla Dolls with people living with dementia, specifically those who are distressed or unable to sleep. As you can imagine, this is a very sort of sensitive group of patients and a very specific group of patients. So we applied for this fund, and I don't know if any of you are familiar. These are the Lulla Dolls, which I'm happy for you to have a go at. See if we get them working. So these little dolls were developed in Scandinavia for use with premature babies and small children. So they have breathing and they have a heartbeat. And the difference with this, the use of this doll, that I thought would be fabulous for transferring and trialling with people with dementia, is that it's not doll therapy in the classic sense of doll therapy that's used, this is my baby, and for people in a residential home perhaps. What we wanted specifically was for it to be a sensory therapy. So we wanted to work out whether the use with small children would be transferable for adults who were distressed. As you know, a hospital is very different. We have infection control issues. People who are in the hospital are sick with medical, clinical, surgical things. So our project was provisionally for 6 months. The criteria and suitability and the consent issues were looked at. We would look at those patients that are ordinarily referred to our service, to the Dementia Care Service, for support with behaviours of distress or with family carer support, etc. The criteria for inclusion in the trial would be for those patients who had 2 or more incidents of distress. They may be under one-to-one observations, or they're having prescription of sedatives due to their distress. So we want to come in and counteract the use of the one-to-one observations, and perhaps, as we know, some people, when they're on one-to-one observations, people who don't fully understand the dementia and the therapeutic activities that can take place often sit and guard. So how can we encourage people to use therapeutic interventions with people? Of course, the suitability of those patients would be discussed with ward staff, and if the patient has family members and carers, we would discuss with them and look at the information giving and consent issues. We've therefore created a whole pack for staff to look through, identifying aims and exclusions, the inclusion, the therapy criteria, and an evidence form for both the dementia care team and ward staff to complete and monitor. A fact sheet for families and carers, so we can talk through the pros and cons of this sensory therapy and get to understand perhaps some of their anxieties about perceived doll therapy and infantilisation. There's a consent form for family members and ward staff, if it's in the person's best interest. There's an agreement and evidence form for the ward staff, so that they're taking responsibility for the trial and the use of the doll. So I've engaged with the matrons on many wards, and they are all very eager to be included in the project. So what we've done with the funding, the main element of the funding, I already had 3 dolls, and it was to purchase an extra 3 dolls so that we can have at least 2 in use on each site and 1 in the laundry. And the main cost is for an administrator, because we want to be really robust in our documentation and our qualitative and quantitative data collection, with the intention of writing it up, whether it works or whether it doesn't. At least we've tried, and we can move on to the next thing. So feedback and documentation will be given by the ward staff, by the relatives, by the carers. There's robust documentation, such as monitoring with something like a Cohen-Mansfield inventory. So we'll access information in a variety of elements. So that's the behaviour chart. We'll review the use of one-to-one observations and what the potential is for the reduction of medications and sedation. The practicalities, of course, are the initial planning. What do we want to get out of this? So kind of work backwards to see what evidence, documentation we need, and how are we going to put this into practice. Engaging the company, I think that means, I don't know what that meant. Engaging, I don't know what company meant. Engaging the company, perhaps the trust as a whole. Sorry?
It might have been community.
It might have been community. I may have just woken up when I read that. Engaging with the whole of the trust, that's the Dementia Care Strategy Group, and getting their acknowledgement that this is a positive project to take forward. Engaging with the ward matrons and the heads of nursing to ensure that they're on board, and then how do we disseminate the need for robust documentation with day staff, night staff, weekend staff. That's the kind of selling it to others, and engage, of course, the whole of the dementia care team, so that we're all on board and we're monitoring daily, a few times a day, these patients. So for the team, for the ward, and for the relatives, as I said, some of the fears that people might have about infantilisation, and that a doll is not appropriate. And we're not just saying it's for women, it's for men as well. For the team, as I said, the most important thing is for us to get an administrator so that we can maintain a running log from start to finish of the project. So timelines, any communication, any meeting with ward staff, the appointment of the administrator. We had a hiccup initially because the young lady that took, by the time you've advertised and interviewed and taken someone on, and then she came for 2 weeks, and then there was a disaster in her home life, so she left and we had to get someone else in. So that was a hiccup. Staff conversations, so it's a constant reinforcement that this is a really positive intervention. Communications, and that could be across the whole trust, to just get the therapists, for example. We can't have meetings with all of the physiotherapists, occupational therapists, radiology, so we need to have communication with them. Version control of documents is really important, because what works initially, when you put it into practice, may need tweaking. And why did we do that? Why have we changed the documentation? So real project plan management, project management. And what are our milestones? We have, like all of us, you don't know who's going to walk through the door of your hospital or your care setting. So we had a trial initially with 2 of the dolls. One patient used the doll in its entirety, but at that time we didn't have all of the documentation in place. Another patient, the family wanted the use of the doll but didn't want the battery pack, so didn't actually want the breathing and the heartbeat. And the lady had made use of the doll to great effect, and when she was discharged, it went to the care home with her, and then her daughter brought it back. So we have all of those issues which are very different from a care home setting, giving someone some doll therapy that's going to stay with them forever. These patients are discharged from hospital. We can't be giving a £50 doll to every patient. So those kinds of things, how do we overcome that disengagement from this doll? How do we get, you know, we've got a doll that's similar but without the battery pack that's £19. So would families be prepared to buy that? Have they got a different therapeutic toy, teddy, cushion at home that could be used for exchange and discharge? And just introducing therapeutic interventions to family members. And maintaining contact with Vicky and Breda is really important, just to ensure that we stay on the right track and get their input and their thoughts about what we can change and how we can progress. As I've said, engagement from the ward matrons is vital so that they can ensure their teams are all on board. How do we disseminate to and engage all staff, including bank staff, who are often the staff who come and sit on a one-to-one? Of course, as I said, it's our team that has the referral for this patient, so it's our job to go and speak to the bank staff and ensure that handover of information is given. Maintaining documentary evidence is vital, and as I've said, day, night and weekend staff. Our milestones, the appointment of a solid administrator, sign off for the documentation pack, which, you know, it involves the patient experience team and trust documentation and the steering and strategy group. Identifying appropriate patients and looking at the lessons learned along the way. So, as I've said, I've got packs here if you wanted to have a look through and look at the kind of thing that we've got and our implementation plan. And if you want to know any more about the dolls, I'm happy to talk you through. Is that okay?
Lovely. Thank you, Elaine. That's really great. So, before I open up to the floor for questions, I just wanted to ask just very quickly one thing. So, there's obviously been some unforeseen hiccups along the way.
Yeah.
And how have you managed them within the time frame of the project? You know, did you have contingency plans in place already, or have you built them as you've developed?
I had a 2-day-a-week administrator who was very happy to take on a 3rd day.
Right.
So he has a very defined role for his 2-day job, and all of this work and the communication issues, documentation, team meetings, other meetings outside specifically for the Lulla Dolls trial.
And just to give people an idea of scale, because I think we spoke about this, the number of people that you've had to speak to in order to implement this project has been a lot more than was anticipated. Shall we say? What was it? 400 something? That you said when you added up all of the staff, the night staff and the ward staff and the domestics and
to ensure that we did have one little doll that was, of course, it gets picked up in the laundry, so we have to be very aware of it not being picked up in the laundry and sent on a 90-degree wash. So of course I've had to meet with the laundry staff and go through what meets infection control needs and what won't absolutely shrink the doll. So we've come to a happy medium. So the dolls come back to the team to go to the laundry and ensure the battery pack's not in it. And I think one it shrunk a little bit. So those fine points that could absolutely ruin the trial.
So, other questions?
How long have you been going with it now?
We said we'd start in February, but as I say, we had because we had the dolls in our possession, we couldn't say before February, no, we're not going to try this with this patient. So that's why we tried, and it actually worked out one of these on each of our acute hospital sites, but we're just keeping it on the radar. So from March, we said March to September. but we haven't had a patient in March that was suitable. You know, as I say, it's a very specific group of patients that this may be suitable for. So we may end up having 2 patients, we may end up having 20, we just don't know. And as I say, the write-up, as long as we've got all of the evidence and the rationale for our work, the write-up, it doesn't matter if it's successful or not. We've tried, and what can we try that's similar or very different next time?
It's how do we capture the learning from that,
Yes,
so that
yeah.
somebody doesn't go off and repeat the same thing or in the same way again,
Yeah.
and just come out with the same answer.
As I say, the evidence that we looked at prior to this was all around doll therapy, and generally with the dolls you dress, undress, change their nappy, and you know, in residential settings. So this is very, very different in an acute hospital setting.
Any other questions?
Well, just one thought, what's the research say about men as well as women using them?
I don't think there's been any difference. I think it's just comfort. I think it's just comfort. So, you know, and in acute hospital settings, there's no evidence of sensory therapy being used. People are so focused on the clinical and the discharge, that it's not something that the majority of staff have ever engaged with.
Do you meet any resistance from the staff when you talk to them about
We've had 1 or 2 who still think it's not appropriate, but you know, personal values and beliefs come into that, and I think until you've talked through and perhaps given staff members the fact sheet to say this is not what we're doing, you know, and we're looking at how has the doll been introduced to the person, you know, are we just going to leave it on the bed and see whether they're attracted to it, whether they like it, or whether they throw it across the room? Are we giving it to a family member? In those 2 patients prior to the trial, the daughter said, I'll take it. So perhaps the daughter just sat with it. I can't recall. We've got it all documented. You know, or was it given to the person? Did they immediately take to it? So we want to capture all of that evidence within the first hour, within 4 hours, within 24, within 72 hours. What difference has this made, and has it made a difference to perhaps, you know, where they would have been given some sedative?
Thank you. Any more questions?
Just want to say, I've got quite a few clients out there in the community that they get a lot of comfort from these dolls.
Especially when they're using Lulla. They're actually using Lulla.
Yeah,
Lulla
not
dolls.
that type of doll.
No.
I mean, a lot of families instinctively go out and buy cuddly dolls.
Yes.
And
Yes.
some people, and they're surrounded, they've got more around
Yes,
and they feel
yeah.
safe. And
Yeah.
there is less use of sedative medication.
Yes. Yeah.
Yeah. It does make a difference.
Yeah. In the community, I think it's a lot more accepted because
Yeah.
once it's theirs, it's theirs.
Yeah.
How do we overcome
That's,
the...
yeah.
Give it back.
Prove that.
Yes. How do we have that exchange?
We have used it on psychiatric wards rather few, but you are right that sometimes there are fights over pain.
Yeah.
You've got to be a bit careful.
Yeah. Yeah. So we will see.
Well, we look forward to hearing the final outcome in September, October time.
Lovely.
Lovely, thank you. Thank you for
Thank you.
coming, I really appreciate it.